Morning, everyone. Let me just get a yes in the chat to confirm that I can be heard. All right. Good morning, everyone. My name is Dr. Kato David. I'm a GP here at Nile International Hospital, where I serve at the emergency department, and I'm also a member of the acute care and emergency medicine team. Today, we are honored to welcome you to this important discussion on acute coronary syndrome, commonly known as heart attack, focusing on what every clinician must know to improve patients' outcomes. I'm privileged to be joined by a distinguished panel of experts, Dr. Asad Muyinda, a highly respected consultant cardiologist specializing in diagnosing and management of complex heart conditions. Dr. Muyinda brings a wealth of international experience and a deep commitment to advancing cardiac care. Dr. Edwin Mulema, a skilled internal medicine physician with extensive expertise in holistic management of adult medical conditions, including critical care of cardiovascular conditions. Dr. Ashraf Shat, an esteemed interventional cardiologist whose advanced expertise in procedures such as coronary angioplasty and stent placement is vital in the emergency treatment of heart attacks. Dr. Shat is on call and ready to offer any valuable insights. All our panelists are proud members of the medical team of Nile International Hospital, where we are dedicated to delivering world-class cardiovascular care. Welcome, everyone, and thank you for being part of this session. Today's session is designed to equip every clinician with critical knowledge and practical skills in the management of acute coronary syndrome. Our key objectives include understanding the definition of acute care syndrome, exploring the various causes and approach in is not recognizing the action of learning how to distinguish these symptoms from other conditions that cause chest pain. We're also going to discuss how certain patient groups, including the elderly, diabetic, may experience a silent heart attack presenting with non-classic symptoms. We shall also review the diagnostic tools. We shall also review the diagnostic tools, including characteristic changes on the electrocardiogram and other key investigations that point towards the diagnosis of a heart attack. We shall outline the principles of emergency management, beginning from the first point of patient contact through ongoing monitoring and focusing on the prevention of common complications associated with acute coronary syndrome. So acute coronary syndrome is a spectrum of conditions associated with sudden reduced blood flow through the coronary arteries. As we shall see, this spectrum includes unstable angina, non-ST elevation myocardial infarction, what we call NSTEMI, and ST elevation myocardial infarction, what we call STEMI. This can be due to reduced coronary artery blood flow or reduced overall systemic blood flow. When cell death results in damaged or destroyed heart tissue, this is usually referred to as a myocardial infarction. And usually this is supported by troponin levels that are above the normal limit. So looking at the anatomy or the blood supply of the heart, This is very key in understanding acute coronary syndrome because it's mainly usually from this blockage of these blood vessels that we get myocardial cell death. So the main blood supply to the heart has its roots from the base of the aorta through the coronary arteries, and it has the various branches as demonstrated. So the route of the blood supply is from the base of the aorta, just after the junction of aortic valve, around the area identified using the laser pointer there. So the branches of the coronary arteries are subdivided into the right coronary artery and the left coronary artery. The left coronary artery later subdivides into the left anterior descending artery, which is very key. It's one of the most dangerous arteries in case it's blocked by a clot. And that's because the left anterior descending artery supplies the walls of the left ventricle, the anterior wall of the left ventricle and the lateral wall of the left ventricle, which is the main pump in the heart. And then it later subdivides the left coronary artery, also subdivides into what we call the left circumflex artery, and that usually supplies the lateral wall of the left ventricle. Then the right coronary artery continues as the posterior descending artery, which is responsible for supplying the posterior interventricular septum and the posterior walls of the right and left ventricle. So over there is an image, a volume rendered image of the blood supply of the heart, which you can look through later on during your free time. So looking at the etiology, the ischemia of the myocardial cells usually occurs when there is an imbalance between oxygen demand and oxygen supply. The myocardial oxygen supply is usually based on about 4 factors, which include the coronary artery blood flow, the systemic blood flow, and the oxygen carrying capacity of blood. The coronary blood flow can be influenced by factors, as we will see later on, that include vasospasms of the coronary arteries, dissection of the coronary arteries, or ruptures, or stenosis of the coronary arteries, or diastolic dysfunction, because the coronary arteries mainly fill up with blood during the diastolic phase of the heart or the cardiac cycle. And then we can have reduced systemic blood flow due to hypotension or blood loss or shock. We can have reduced oxygen carrying capacity of blood due to anemia, due to respiratory failure. We can also have increased myocardial oxygen demand, bringing about myocardial ischemia, and that is usually contributed to by increased heart rates that can be due to increased metabolic demands of the body, stimulating the neurohormonal system and increasing the heart rate. So things like dehydration, blood loss, hypotension, infection, thyrotoxicosis, or surgery, or chronic anemia. And then we can have myocardial oxygen demand also increased by factors like that influence the contractility of the heart, or other things like abnormal rhythms of the heart, like tachyarrhythmias. So we have particular risk factors associated with acute coronary syndrome. We have the modifiable and the non-modifiable factors. The modifiable can include diabetes, obesity, smoking, and the others listed on the slide. We can have non-modifiable risk factors like age, family history, race, and ethnicity. These are all key in diagnosing acute coronary syndrome during the process of history taking, the initial steps. So going on, we have a classification of myocardial infarction based on types according to the European Society of Cardiology. We have type 1, which is usually associated with an atherosclerotic plaque or a thrombus, as we shall see, or as you see demonstrated in the diagrams, where we have an atherosclerotic plaque forming, and then later on, if it ruptures, because of the exposure of the internal in the film of the blood vessel, we have a clot or a thrombus forming within the coronary arteries. So as you can see demonstrated, we have normal blood flow, and then we have plaque formation. We can have plaque rupture and thrombus formation, resulting into unstable angina, ST elevation myocardial infarction, or non-ST elevation myocardial infarction. ST elevation myocardial infarction usually occurs if there's complete blockage of the coronary arteries, leading to absolute myocardial infarction due to absence of blood flow. Type 2 myocardial infarction is usually associated with abnormalities of the coronary arteries that can include vasospasms, that can include non-atherosclerotic coronary artery dissection, that can include an imbalance between the oxygen supply and oxygen demand, as we've already discussed, or other variants of angina, which we refer to as the Prinzmetal's angina, where we have still vasospasms of the coronary arteries. Type 3 myocardial infarction, usually this is one where the patient dies before the biomarkers can be obtained, as we shall see later on, the cardiac enzymes, the results of the cardiac enzymes, or they are not adequately raised to provide evidence of myocardial infarction, but later on postmortem, there's evidence of myocardial or cardiac death. Type 4 is where interventions that are done to the heart bring about death of myocardial cells. For example, primary percutaneous interventions. That's type 4. Type 4B is usually related to stenting, where a stent is put in the coronary arteries and later on develops clots within the stent. Type 4C is where there is restenosis, where we have a stent placed, as you may see, but then later on, the blood vessel still goes ahead and reduces in size. Type 5 is where we have myocardial infarction as a result of the CABG or coronary artery bypass surgery or grafting. So going to the complications of acute coronary syndrome or heart attack, we have various complications that can include electrical complications like ventricular fibrillations, abnormal rhythms of the heart as a result of death of the myocardium, or we can have complications from pump failures as a result of death of the myocardium, causing heart failure, cardiogenic shock. We can have mechanical complications, including ventricular rupture, septum rupture, rupture of the papillary muscles. We can have complications associated with inflammation, for example, pericarditis, Dressler syndrome. We can have structural changes of the heart. We can have thromboembolic resulting from, for example, instances where we have ventricular aneurysms and abnormal blood flow in the heart. We can have clots forming and going to other places of the body, or we can have reinfarction. Now, going to the clinical presentation of acute chest syndrome, the main or the key symptom that we usually interface with is chest pain. And then we can also have palpitations. We can have shortness of breath. It's usually associated with exertional dyspnea, where a patient presents with decreased exercising tolerance, where when they try to exercise, they get short of breath. And then we can have some abdominal symptoms like nausea, vomiting, indigestion, epigastric pain. We can have diaphoresis, sweating, usually due to the sympathetic drive or the adrenaline rush. You can also have patients presenting with altered mentation, where they have restlessness, they feel dizzy, they feel lightheaded, or even they feel a sensation of what they call impending doom or impending death. So in terms of the pain, the character of the pain is usually some kind of, someone feels like there's something seated on their chest, very heavy. For example, I feel like an elephant is seated in their chest. It can be a crushing kind of pain. It can be a constricting kind of pain, as if something is tied around the chest. It can be strangulating kind of pain. That's the character of the pain, if you ask the patient to describe their pain. The onset of the pain usually can range between gradual to sudden, but commonly gradual, and it's usually exacerbated by exercise. And in case you give these patients nitroglycerin, as we shall see, for some of them that have stable angina, they may respond because nitroglycerin dilates the blood vessels of the heart. And also sometimes this is very key. Sometimes these patients also have a tendency of presenting, as we've said, with abdominal symptoms and responding to what we call the gastrointestinal cocktail, which includes drugs like omeprazole, Nospa, and so on and so forth. But it's always very key to continue monitoring these patients to be sure they're not having something more than just what usually diagnosed as peptic ulcer disease. The pain usually radiates to the left part of the body, the left upper limb mainly. So the left shoulder, the arms, the wrist, the fingers, the neck, the throat, the lower jaw, and the teeth. And not infrequently, this pain could also radiate to the back. Rarely a cardiac pain. So any pain that is below the navel or above the nose is rarely cardiac pain. Any pain in between those can really be cardiac pain. So in terms of the onset, the time course, the pain usually, for angina, the pain can be as brief as 2 minutes and relieved on rest. But for acute chest syndrome, the pain comes at rest. Actually, the patient is at rest. And it's exacerbated, as we said, with exercise. And it can be variable, but generally it lasts longer than 30 minutes. Any pain that goes beyond 24 hours is also usually unlikely acute chest syndrome, unless there's continued damage of the myocardium. So we have what we call angina equivalents in the elderly, women and other people with diabetes or mental illnesses, or patients that are sedated. These may not present with the obvious symptoms that we've seen before. They may present with symptoms as simple as diaphoresis or difficulties breathing or epigastric pain or change in well-being. And that's because the patients with diabetes have autonomic neuropathy. So their autonomous nervous system usually has issues recognizing pain. And then also those that have mental illnesses may have issues recollecting the recent symptoms associated with acute coronary syndrome. So the following historical features usually increase the likeliness of acute chest syndrome. If the patient has a history of an event of myocardial infarction in the past, or they have the risk factors we mentioned, like age, sex, or diabetes, or hypertension, dyslipidemias, or they smoke cigarettes, or they have recent use of sympathomimetic drugs like cocaine. So there are other pains that may present, chest pains that may present but are not cardiac pains. So pleuritic chest pains, where a patient can identify with a finger or point to a particular part of the chest paining. And then also mild lower abdominal pains, that are constant, lasting for long periods of time, pains that are increased with movement of the chest, like breathing in and out, or palpation or touching of the chest. Those are usually rarely cardiac pains that can be associated with other complications of chest conditions like pneumonia, pleuritis, pericarditis, and so on and so forth. Pains that radiate to the lower extremities, as we've already said, are also rarely cardiac pains. So there are other emergency conditions which patients may present with that may not be acute chest syndrome. The differential diagnosis they include pulmonary embolism, spontaneous pneumothorax, acute pericarditis, heart failure, pneumonia, asthma, musculoskeletal conditions like costochondritis, or other GI causes like bleeding peptic ulcer disease, dyspepsia, esophageal ruptures. So, key in dealing with these patients is the physical examination. Always we start with our ABCDE, so the airway, the breathing, circulation, disability, and exposure of the patient. And we look for signs of systemic hypoperfusion, things like hypotension, tachycardia, impaired cognition, cool extremities, pale skin, and then also we look for signs of evidence of heart failure in this S3 gallops, or worsening mitral regurgitation murmurs. And then we also do a focused neurological exam to rule out focal lesions in the brain, causes and big complications of myocardial infarctions are already, as we've already discussed, and also rule out cognitive deficits that may preclude, as we shall see later on, safe use of thrombolytic therapy. In terms of investigations, we usually do the first investigation on contact with these patients is an ECG, an electrocardiogram. So this is the simple demonstration of an electrocardiogram. The wave, the main wave, we have the P waves, the QRS complex, and the T waves. The P wave is because of atrial depolarization, the QRS because of ventricular depolarization, and the T wave is because of ventricular repolarization. So over here, you can see an almost normal ECG. Attached to the wave there is the times of the various intervals and segments of the ECG. You can go through later on. But to note importantly, in a normal ECG, ECG interpretation is a detailed discussion which may not complete just within a few minutes. But we usually look for a P wave followed by a QRS complex followed by a T wave, and then other abnormalities we shall see on the ECGs that will be associated with myocardial infarction. ECG for these patients within 10 minutes. For patients with suspected myocardial infarction. And as you can see demonstrated over there, we usually look for an ST elevation. So we look at the PR. The PR segment is used as our isoelectric line or as the baseline. And we look at as marked there by number 2, the J point of the ST segment. So if the ST segment is more than 2 small squares from the PR interval or the isoelectric line, we consider that ST elevation, and other variants, as we shall see in the next slide. For patients whose ECG is non-diagnostic, we usually repeat the ECG every 20 to 30 minutes in case there's increased or ongoing suspicion of acute coronary syndrome. So the features of an ECG that are suggestive of acute myocardial ischemia are listed in the pictogram there. ST elevation at the J point in 2 contiguous leads, That's two leads that are associated with one part of the heart, as we shall see, with a cutoff point of greater than 1 millimeter elevation in the ST segment. That is one small square in leads other than lead V2 and V3. In lead V2 and V3, the cutoff points may be higher, as great as 2 millimeters or 2 small squares in men over the age of 40, or greater than 2.5 millimeters in men over the age of 40, or greater than or equal to 1.5 millimeters in women, regardless of age. And then we can also have ST depression and T-wave changes. So an ST depression that is less than 0.5 millimeters in 2 contiguous leads, or T-wave inversions greater than 1 millimeter in 2 contiguous leads with prominent R waves or an RS ratio greater than 1. We shall look at these features when we are analyzing some of the ECGs of patients we've interacted with myocardial infarction. Or when we have Q-wave, new onset left bundle branch block, can also be one of the features on ECG of myocardial infarction. These are some of the other features that can be associated, can be seen on an ECG of a patient with myocardial infarction. But later on, in case there's an unrecognized myocardial infarction, patients will present on the ECG. Patients will have what we call Q waves. They are usually signs of long-standing myocardial infarction. And then later on, as we shall see, if we do imaging, we might see variable myocardial loss of variable myocardial pattern and ischemic etiology. So these are some of the ways the ST segment or the wave progresses in myocardial infarction. We can have initial ST depression, then ST elevation, so ST depression, later on ST elevation. The initial stages, you can also have tented high T waves. And then we can also have T-wave inversion, and later on, in case there's reperfusion, we will have the normal wave back as we saw it in the normal ECG. So these are still similar description of the progress of the STT changes on an ECG of a patient with myocardial infarction. So when we try to localize the myocardial infarction, as we've already noted, we usually do an ECG, and the leads that are affected can help us point out which part of the which part of the heart is affected, or which part of the myocardium is affected. So usually if it's an anterior wall, it's V1 to V4. If it's an inferior wall, it's lead 2, lead 3, and lead AVF, as we shall see. And that usually means right coronary artery blockage. Or if it's a lateral, the lateral wall is usually leads 1, AVL, V5, and V6. And if it's a posterior wall, it's V7, leads V7 and V9. We can also do echocardiogram for these patients later on when they are stable, which can demonstrate wall motion abnormalities, where if it's an anterior wall, you will see anterior wall motion abnormality. If it's a posterior wall, you will see posterior wall motion abnormalities. But usually the gold standard diagnosis of blockage in the coronary arteries is coronary angiogram, which will demonstrate either left anterior descending occlusion, posterior descending occlusion, and so on and so forth, as demonstrated in these pictograms over here. So that's demonstrating the same thing. If you have anterior wall infarction, you will see that's the ECG parts of the ECG, the various leads of that demonstrate the parts of the heart that where if it's septal, we have V1, V2, V5, V6, lateral, lead 1, and so on and so forth. So this is a normal ECG as well, already demonstrated for you. We have our P wave followed by QRS followed by T. We usually use lead 2 as our rhythm strip. So there are various things that usually go through when you're analyzing an ECG. You look at the rhythm, you look at the rate, the rhythm, the axis, and then look at the various waves and the segments and intervals. But basically, this is what a normal ECG looks like as compared to the abnormal ones that we're going to see. So this is an ECG where we have anterior wall MI or anterior wall myocardial infarction. And as you can see, we have ST elevation as demonstrated by the dashes in leads V1, V4, V3. So we have our PR segment here, and you can see our J point starts almost 4 small squares away from the PR interval or the isoelectric line. And then we also have reciprocal changes in lead 3, where we're having ST depression demonstrated there. And then we have this ECG of a patient that had an acute inferior wall MI. As you can see, we have ST elevation in lead 2, lead AVF, and lead 3. And we have reciprocal changes in as ST depression in lead V1, V2, and V3. This is an ECG of a patient that had an inferior wall myocardial infarction still. And usually for patients that have inferior wall myocardial infarction, we always prefer to do what we call a right-sided or right side chest ECG to rule out right ventricular infarction or right ventricular involvement. This is a patient that had, this is an ECG of a patient that had lateral wall myocardial infarction, as you can see demonstrated. We have ST elevation in leads 1, lead AVL, lead V5 and V6, as you can see demonstrated by the dashes. And then the reciprocal changes in lead 3 AVF, also confirming the diagnosis for that patient. These are other ECGs, which because of time we may not go through, but you later on the presentation will be forwarded and you can go through on your own. This ECG, I put this ECG here because we have these T waves. These high T waves usually can be an early feature of myocardial infarction, as you can see, almost 2 times the QRS, the upper limit of the QRS complex. So in terms of other diagnostic investigations, we have cardiac markers and usually do troponin, CKMB, myoglobin, and LDH. But the key here is CKMB and troponin. CKMB can help us detect myocardial infarction early, as you can see traces early, but it also goes down very fast. And then troponin can help us detect ongoing myocardial infarction as it traces a little bit later than CKMB, but remains elevated for longer periods of time. The other things that can cause, so the key here is the gold standard diagnostic investigation in terms of the labs is troponin I. However, there are things that can cause elevations in troponin I, like heart failure, myocarditis, cardiomyopathies, coronary vascularization, and other issues. This is a very busy slide. It's demonstrating the diagnostic relating with troponin and what is supposed to be concluded in respect to the various troponin variables. We won't go through that because of time. But importantly is this graph here, where as we receive the patient in the first few minutes, 10 minutes, we do the ECG. Then we check out if the patient's ECG is normal. We still do the troponin because the patient has features of signs and symptoms of acute coronary syndrome. And if it's negative, we consider this to be stable angina. And we shall see how that patient is supposed to be managed going forward. But if we see T-wave abnormalities like T-wave inversions or ST depression, and we go ahead and do the troponin, if the patient's troponin is negative, we consider that to be unstable angina. But if the patient's troponin is positive, we consider that to be non-ST elevation myocardial infarction, where there are no obvious features of ST elevation on the ECG, but the patient's troponin is positive, meaning the patient is having myocardial infarction, but not yet demonstrating features of ST elevation. And this is usually because there's no transmural death of the myocardial infarction. Now, if you have transmural death of the myocardium, we have ST elevation on the ECG, and usually this is what we refer to as ST elevation myocardial infarction. We do the patient's troponin, and it's positive or elevated above the upper limit. We diagnose the patient with ST elevation myocardial infarction. We can also have patients who have ST elevation, but with a negative troponin, commonly in circumstances like vasospastic angina. So the management of these patients is the key here. Usually we of course listen to the patient's history, then we do an emergency service assessment where we monitor the ABCDE as I've already demonstrated. And you should always be prepared to do CPR and defibrillation in case these patients deteriorate. And then usually the initial management can be summarized into a mnemonic called MONARCH, where we give these patients to morphine to relieve the anxiety, and then oxygen. The oxygen is supposed to be given cautiously only for patients whose saturations below 92, and our aim is to maintain their saturations at above 95. But we usually do this cautious. We don't give my patients with myocardial infarction oxygen without really noting that it's really necessary. We can also give nitrates, NTG, usually sublingual. As we shall see, this helps with coronary artery dilation and relieving the pain of the patients. Then aspirin, to ensure rest and relaxation of these patients, as anxiety can exacerbate the symptoms by increasing the heart rate, and always do continuous ECG monitoring. So morphine, we can start as low as 2.5 to 10 milligrams intravenously. And usually we always give IV metoclopramide along with the morphine because it has a tendency of causing vomiting. And also these patients usually commonly present with gastric symptoms like vomiting. You can have sublingual nitrates, 5 milligrams, that helps with dilation of the coronary arteries and improving blood flow to the heart. But the key here is in the initial management of these patients, once we confirm they are having an acute chest syndrome, is giving them aspirin, 300 milligrams. That's about 4 tablets of the common we have with the 75 milligram tablets. I usually give them the non-enteric coated chewable or soluble tablets, not the enteric coated ones, which take long to be absorbed. Then on top of aspirin, we always give these patients clopidogrel or prasugrel or ticagrel, depending on the planned intervention going forward for the patient, whether it's pulmonary percutaneous intervention or it's thrombolysis or conservative management. Usually, if we plan to do fibrinolysis for these patients, clopidogrel is a better drug to use. But if we plan no pulmonary percutaneous intervention or fibrinolysis, then ticagrel can be a better drug to go with. In addition, we always also give these patients heparin or fandoparinax, depending on, again, still the hemodynamic stability of the patient and the plan for these patients going forward. Within 24 hours, we also like to give these patients high-dose statins. So atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. for those patients that present with very high heart rate, we can also give them beta blockers to try and reduce the heart rate and reduce the myocardial oxygen demand. However, we should take caution in patients that have existing comorbidities like asthma, heart failure, hypertension, and bradycardia, as beta blockers can worsen these symptoms. And also in patients who have acute coronary syndrome due to acute cocaine intoxication, beta blockers may worsen their coronary artery, may worsen their myocardial infarction. When it comes to ST elevation myocardial infarction, the key here is quick reperfusion or quick reestablishment of blood flow to the heart. And this should be done in 30 minutes from the arrival of the patient, or if the patient has already been diagnosed, 10 minutes from the ECG diagnosis. Of course, the other factors which should be put into consideration before doing thrombolysis. Thrombolysis is one of the ways we can ensure quick reperfusion of the patient, or what we call fibrinolysis. The other factors we should put into consideration before doing for patients fibrinolysis, like the bleeding risk, the stability of the patient, the blood pressures. For BPs that are less than 90, we have to be cautious. For BPs that are greater than 180/100, very cautious. And patients who have these, who have cardiovascular accidents or who are pregnant, may better benefit from another form of reperfusion, which is the percutaneous coronary intervention. So the thrombolytic drugs that we have, the tissue plasminogen activators, we have alteplase, and that is usually given as 15 milligrams, a bolus of 15 milligrams, and followed by 0.75 milligrams per kg for over 30 minutes, not exceeding 50 milligrams, and then later on 0.5 milligrams per kg, not exceeding 35 milligrams over the next 60 minutes. The other drug that is seemingly being phased out is streptokinase, and that's because of its high side effect profile and hypersensitivity. As from the history, this drug was actually developed from Staphylococcus. So the body, for people who have had strep or staph infections, they can get neutralizing antibodies against this drug. So it's usually nowadays rarely used, but also used with caution. The other TPAs we can have is reteplase and tenecteplase. Again, depending on the hemodynamic stability of the patient and the intervention going forward, these we can choose from any of these. In terms of management, the key thing here as well is to prevent reinfarction. That is for patients that have completed thrombolysis or that will have done percutaneous intervention. We usually give them unfractionated heparin or low molecular weight heparin, the brands of Lexane, at 1 milligram per kg start, and then 40 milligrams OD, or we can use, as we have already mentioned, Fandoparinax, 2.5 milligrams percutaneous OD. But this is usually not recommended in patients who undergo, Fandoparinax usually not recommended in patients who undergo percutaneous intervention. We always give these patients SCE inhibitors, angiotensin converting enzyme inhibitors, to prevent one of the complications we have already seen associated with ventricular remodeling. And this will be started in 24 hours. In Africans, you can also use angiotensin receptor blockers, or you can combine this with aldosterone receptor blockers, depending on the presentation of the patient. And then percutaneous intervention is part of the management. As you see demonstrated there, we have a stent put in a balloon, and then the balloon removed and the stent left in place to allow continuous circulation. And usually the balloon is removed along with the clot. But if the patient is, and this PCI is usually associated with 50% more reduction in death and reinfarction as compared to thrombolysis. So it has higher chances and quicker recovery of the patient. But it should be performed. It should be performed in all patients with STEMI and the ischemic symptoms of less than 12 hours. It can be done in patients with ongoing ischemic symptoms above 12 hours, depending on if the patient has signs of continuous or continuing myocardial infarction. We usually base this on particular scores. We have the TIMI score and the GRACE score. We shall attach those at the end of the presentation if anyone wants to go through them. And also, PCI always is the key for unstable patients. So those that have ventricular fibrillation, heart failure, or shock, the gold standard is percutaneous primary percutaneous intervention, coronary intervention. Then, in case we can't really do PCI for any patient for any reason, then the way forward is coronary artery bypass, rapid surgery, what we call the CABG or CABG. In terms of prevention, as you know, prevention is better than cure. We always encourage healthy lifestyle, that is good diet, regular exercise, no smoking, weight control, stress management, and also reducing the risk factors like controlling cholesterol levels. We have an open cardiology clinic. You can always come in and we screen you for any of these conditions like hypertension and diabetes. Then also medications for patients who are at risk of these conditions like beta blockers and SCE inhibitors. And then regular follow-up care and medical checkups, and any case the inevitable happens, cardiac rehabilitation for patients that have undergone myocardial infarction interventions. Yeah, thank you very much. That's the end of the presentation. Thank you for listening. For those that have not given your heart to God, give your heart to God. It's the best thing, and give him your whole heart. Right now, we shall invite any questions. First, maybe before we invite any questions, we have. Let me invite Dr. Let me invite Dr. Edwin Mulema, the physician, to make comments.
Okay, thank you so much. Thank you so much, Dr. Kato, for that brilliant presentation. So I'll go first, and then my senior Dr. Sad will come in to wrap up. Yeah, acute coronary syndrome is a very common thing with our population now, where people are becoming sedentary, people are gaining weight. It's very common. So it becomes very bad for anyone to sit at any emergency place or to see a patient without knowing how to recognize it. Because acute coronary syndrome is a killer across the world, and more in the low and middle income country. So, as I said, it's very, very important to recognize. And the key here is the history that is being taken from the patient. So if someone at triage makes a mistake, patient has neck pain, he's sent to the neurosurgeon. The patient visits the neurosurgeon, the pain is radiating to the neck. They're ignoring a possibility that could be what? Acute coronary syndrome, can be an MI. So when you look at the actual symptoms the patient presents with, the patients present with chest discomfort, which can be described as pain, but also it can be described as pressure. Actually, what we say, the patient does like this. I remember my professor demonstrating. They say, you get it? The moment the patient is able to point, so when you're taking the history, if the patient points with the finger, then it makes a cardiac cause unlikely, because this is almost somatic pain. But visceral, the patient is hardly failing to tell where exactly the patient pain is coming from, so they're just putting that fist on the chest. That makes it likely to be cardiac cause. There's heaviness. And then the pain can also be burning. So here you go and someone who manages peptic ulcers, prepare for an endoscopy. And as they're doing the endoscopy, the patient passes on. But as you are the emergency department, then you give your IV omeprazole, then the pain persists. Then you still say, okay, this omeprazole, maybe the brand is the problem. You change to another omeprazole, the patient is going to die. Think outside the box. This can be inferior with MI, because what separates the stomach from the inferior part of the heart is just the diaphragm. And easily inferior. I remember so many years ago, some lady we saw here in this place, about 8 years ago. Actually, I still see her. She came in with epigastric pain. We gave omeprazole. The pain wasn't reducing. She was diabetic. As he clearly said, we have what we call angina equivalents. These patients will present with unspecific symptoms. So just think outside the box. We gave omeprazole. The patient wasn't improving. We do the ECG, and you have elevation in lead 2, AVF, lead 3, and that is typical what? MI, inferior MI. So we have to refer the patient. So when the history is very important for all clinicians in recognizing this disease. So when you're taking the history, you're asking yourself, are these symptoms cardiac? Very, very important. And you're saying, okay, this is most likely from the heart. And then the second thing, is it proper? The category is into 3. Is it cardiac? Is it probably cardiac? Or is it likely non-cardiac? Because as he said, there are so many other causes. Like a patient who has pneumonia, who's going to come with still chest pain. A patient, most commonly nowadays, we have had the viral flu moving around and people have a lot of chest pains. And it is more pleuritic pain. Patients, when they take a deep breath, the pain increases. That is unlikely to be cardiac. The heart is very deep. So when you touch the chest, I tell my patients usually, if I palpate you like this and you say, the heart is deep, this is a chest wall pain. You get it? So before you leave the patient, you've asked yourself, is this their heart? Is this likely to be their heart? Or is this unlikely to be the heart driving the symptom? For any clinician, that's extremely important. And with that, you're doing it very, very, very fast. We recently had one patient, a Canadian patient, who came here. He had had chest pain. That's about 2 months ago. He had had chest pain for over 3 days. So they called me at 5. I tell them to come here. And the pain was very, very severe. The next time we knew when he was here, he had got very acute heart failure. These patients get very bad heart failure because their hearts are not chronically sustaining the disease. So their hearts are normal. So when the heart fails, they easily get cardiogenic shock. So he was hardly breathing here, but the pain was very severe, had been on and off for the last 3 days. And then when he came here, we really did, and he had multiple vessel disease. I'll discuss this patient at the end. So anyway, that is very important. I really emphasize this to any clinician before you say, because medicine is tricky. Medicine is 1 + 1 = 2. If you send the patient for ECG and you already lost from the history, and then you see some things that are elevated in confusion gains momentum. Right? When you see something that elevated it's like usually in V2, V3, you have some little elevation. So you left the history without knowing that this is critical chest pain. Then you're clearing the line, you send the patient for ECG. ECG comes back, you see things a little bit elevated. Boom. You give aspirin. You give what? What about if it's aortic dissection? In aortic dissection, if you dare give the management for acute coronary syndrome, the patient is going to die because their aorta is already dissected. Then you're going to, there is some clot that is prevailing, that is attached to the aneurysm. So for you're going to give, like saying you give what, and then the patient is going to die. So I really emphasize the need to know the history, and you take it very fast, like in emergency, we normally do. So then chest pain equivalent symptoms, as he said, patients can come with dyspnea, like epigastric pain, I said, pain in the left and right arm. So you just think acute coronary syndrome. Like in emergency, what we do, you only think about what is going to kill the patient first. A PE can also, patients come with chest pain, pulmonary embolism. So, and when you get confusion from there, you're going to do your ECG, and it will show you right ventricular strain. And then also, as he said, sometimes troponin is raised in PE and then bars. You're lost. But most of the time, if you took your history very well, then you can know that, okay, this is really the risk, the well score, the patient is most likely to have a PE, unlikely to have an acute coronary syndrome. So things should make sense, things should tie up. The misdiagnosis and delayed diagnosis is due to incomplete history being taken. So I really emphasize that to any clinician. Then from the history, we go on to examine the patient. So what you're examining from the patient, you're most interested in the complications of the acute coronary syndrome. In the complication of the acute coronary syndrome, is my patient having cardiogenic shock? Like they're having severe difficulty in breathing, their BPs are crashed. Some like when you showed you inferior wall MI, patients will have bradycardia and hypotension. So the patients have bradycardia and hypotension, not because of cardiogenic shock, but because it's the inferior part of the heart that is affected. So at that point, your management, you have to think through. If you just go with the book and then you give nitroglycerin, you're going to crush the pressure further. The patient where they has bradycardia, when you give metoprolol, you will cause more problems. So still thinking through what exactly is happening to this patient. Am I having a high-risk patient? Am I having a very high-risk patient? The hemodynamic stability. In patients with anterior wall MI, normally they have hypertension. Like that patient I'm talking about, the pressure was very, very high. And the pressure was very, very high and they have a tachycardia. So management is tailored to the patient. There is nothing like you just do the same thing throughout. No. You have the baseline, but when you're examining the patient, you're trying to see how you're going to be managing these complications of acute coronary syndromes that the patient has also presented with. Such that in the next 10 minutes, as he said, you have a 12-lead ECG. The 12-lead ECG is further just going to tell you if you're having an ST elevation, ST segment elevation, non-ST segment elevation. Like it's just going to further classify, sub-classify what you're dealing with. Such that when you have a complete ST elevation, as he showed you, then you're thinking that this patient, the vessel is totally blocked, and all I need is reperfusion. So if the patient, like I gave you that man who came here, he had spent 2 days, 3 days actually, with chest pain. You give reperfusion, alteplase, you give what is out of the 12 window. At that point, giving him fibrinolysis, you're causing more harm. So yes, I'm seeing ST elevation, but it has taken longer than 12 hours. So I cannot give this medicine. So still history is important. But if it's less than that time, then you can still give the medicine. So at that point, such a facility in the eastern region, you cannot be without alteplase at any point. It's very, very important because any person, any politician, any person can require that fibrinolysis because we are a little bit far from the hub where PCI can be done, where primary percutaneous coronary intervention can be done. By the time you send the patient to Heart Institute, it may be very late. Yes, our ambulance, I think not here. I think it can go by 2 hours, which is okay. But our patients come in late. In 120 minutes, you have to reach the patient at least to the what? To where they can do a PCI. You see what I'm saying? So you're doing the ECG still to help you now know what exactly you're dealing with. So if it is elevation, I'm dealing with ST segment elevation, that is NMI most likely, and I need reperfusion. And if it is non-ST elevation, then you know that then you have inverted T waves, or you have all those T wave changes. Then again, you go ahead and you know that maybe the blood supply has reduced to 10 to 15%, as he said, and all you need at that point is to tie up. If it's a high risk, despite it being a non-ST elevation MI, there is need to doing PCI if the patient can be in cardiogenic shock. So that is in ischemia then. But all along, the patient is still complaining of chest pain. So this is very important. And then, as he hinted on this, I won't say it again. And then the second step at that point is to meet, but as you're discussing all this, when you put in the line, you send for troponin. So at that point, the lab should know whenever you see troponin as a request. Last time we had troponin request, and it's a little bit late. It's an emergency. So you get us the results very fast. All troponin results should have fast lane in the lab. If you're doing malaria test and you see troponin, you hang on, give the malaria, do the troponin test, because there's someone we need to make a decision on. So when you have troponin, sometimes the the patient comes and you have ST elevation, but the troponin is normal. Right? So troponin normal at 0 doesn't mean that there is no problem. That is extremely important for the clinician here, my brother. You remember that patient you have had recently had inverted T waves, and the first troponin that was done was normal, but the subsequent troponins started increasing, and then they came down. So when you're doing the troponin, you're asking yourself, is there a very low risk? Eh? You rule out or you rule in? So still all these things are in a spectrum. So you're talking of at the first hour, then if there is there is increased likelihood you're repeating troponin in hour 2. So if I did at hour 1 and I've not gotten the result, and then I repeat at hour 2, I don't get the result. So what I'm meaning, people in the lab, I don't know, they're not represented. So when we need to get the results very fast at hour 1, then repeat again at hour 2, then again, if still you have a suspicion, or if at hour 2 is still normal, then you rule out it's being most likely what? Cardiac cause, especially you're doing this for non-ST elevation MI, where you have some few inverted T waves. So you're repeating and you're ruling out. But if you repeat and then it is increasing, then your troponin is increasing from 0 hour, then to 1 hour, then 2 hour, then you make it very highly likelihood. So you talk of a non-ST elevation MI. And if you're in the middle, the ECG wasn't so suggestive, then you repeat at 3 hours. So troponins can be repeated. As he talked about, I just needed a little bit on the management before I call Dr. Assad. Oxygen, it's not routine that every patient you put oxygen. We now talk of 90. If the saturation is above 90, no need for oxygen. If it's below 90, you put oxygen. Nitrates, you go slow on them. If the patient has a very low blood pressure, you don't want to crush that blood pressure. And even sometimes, if the blood pressure is, if the patient has a very low blood pressure, still don't give nitrates. But they sometimes can help reduce the what? The pain. Then morphine is important, preferably intravenous. You can also give it. And then we need to get the IV metoprolol. Yeah, IV metoprolol is important in such situation. So I wanted to just discuss that successful case we had about, as I said, 2 months ago. So this man calls me at around 5 that he has chest pain. I tell him to come to hospital. And then when he comes, he has very severe chest pain. He's from Canada. He has very severe chest pain. And when we did the ECG, all the things, all of them were elevated. I wish he had carried the ECG here, but I think he has not put in the presentation. So it was multi-vessel disease. He's diabetic. And it wasn't only one side. Like when you look at it, you even could think this is pericarditis because everywhere was elevated. He had multi-vessel disease. So we successfully managed him from here. And at that point, he was hardly breathing when he came to us. He was really fighting for life. So we gave him the furosemide because he was getting acute heart failure. And then definitely gave him the morphine. He was on oxygen. Then I really instructed the ambulance to rush to Kampala. Fortunately, he was dashed to Nakasero. So when we reached Nakasero, they did the angiogram and all the vessels were blocked. So at that point, stenting one vessel and leaving the other was a waste of time. So they admitted the patient in ICU only to continuously manage and get him out of the heart failure. He developed a pneumonia a little bit and had to be taken to South Africa to do a cabbage, as we showed you, the coronary artery bypass graft. So fortunately, he's back in India. Very, very happy. He likes me so much. So what I'm saying here is but what was important, when they reached the emergency, people hurried to do the ECG. Then the troponin, in the case of the lab, we had the troponin very fast. So we stabilized the patient. We are almost 3-hour drive from Kampala, but successfully he reached very fine. We had given the initial treatment. Definitely we couldn't give them fibrinolysis because he was out of what? Of the window. So so many other successful stories at the emergency, but they all count on a doctor sitting. It is illegal for a doctor to sit at the emergency of any hospital and you cannot really pick up this silent sign because we say time is muscle in heart failure. Time is muscle. You will send the patient for chest X-ray, yet he has an MRI. So that's what I wanted to share, and thank you so much. I think at this point, I want to invite Dr. Assad. Yes, my senior, then you can say something.
Thank you, Dr. Drin. I was busy listening. Firstly, thanks, Dr. Kato. It really shows you put in a lot of time. And thanks, Dr. Edrin, for the close mentoring of your juniors. I think that's what we need. Yes, Dr. Edrin, you've really summarized a lot of things in my talk. And I think you've saved me from talking a lot. And I totally agree. Time is muscle for the heart. And when it comes to the brain, I know Dr. Hamis will say that brain is time or time is brain or whatever. I would like to, yes, STEMI, you'll always hear STEMI and STEMI, but don't get surprised when you start hearing words like occlusive myocardial infarction. Right now, there's a paradigm shift. You will see other centers now preferring to say occlusive myocardial infarction, not necessarily NSTEMI or STEMI. Reason why is that emerging? Sometimes patients are having significant myocardial damage or having significant occlusion with the risk of increased mortality, but not necessarily that they're having ST elevation. And a few studies, when they tried to reclassify those patients, patients who had NSTEMI but went on to do angio, that patients who were found to have significant occlusion, yet under normal circumstances, these were patients who don't have immediate stenting. So reclassification of such patients in a way indirectly reduced their morbidity and mortality by them having quick intervention or quick PCI that wouldn't have happened if we had stuck to just STEMI and NSTEMI. But in our setting, of course, we have to do that way. So that brings me to the part. Sometimes the ECG may be very hard. You need to look out for very subtle changes in addition to the sequential changes that Dr. Adrian was talking about. I would like to interest you in different patterns of the ECG that may portend occlusive myocardial infarction, or they may be a predictor of ongoing myocardial injury. The winter pattern, the hyperacute T waves, and maybe those in advanced centers, there is now what we call the Aslang phenomena. But you need to be conversant with the hyperacute T waves and the winter. And in the winter, you may not even see the elevation. You may just see T-like wave inversion. Maybe what I've forgotten is the Wallen's pattern. All those are occlusive myocardial infarction equivalent or STEMI equivalents. A very nice talk about RV wall infarction, in that you have to be very careful. These patients are preload sensitive. You have to be very careful in giving nitrates to these patients. The issue is, how do you tell that there is an RV wall infarction? Yes, about 40% of patients with inferior STEMI may tend to have RV wall extension of infarction. So yes, so in this case, you need to look at the inferior leads. Usually, lead 3, if it's elevated, it is a marker, because it's pointing mainly in the right side, it's a marker of probable, it's a mark of inferior infarction. Now the issue is there RV wall infarction? Then you can go on and look at leads V1. Look out for elevation in there. Sometimes you may find depression in lead 2. Dr. Kato projected a slide of inferior infarction, but actually it was not just inferior infarction, and what she pointed as reciprocal changes in the posterior leads was actually no reciprocal changes in V1 and V2. What he said reciprocal was actually posterior extension of that infarction. Quite interesting, to very interesting ECGs there. Now, in our setting, upon teasing out that, and the ECG is not only for a medical officer, a nurse should be able to pick out red flag signs on the ECG. A clinical officer should be able to pick out red flag signs on the ECG, even before a medical officer, because it is the nurse to activate the code that there is something wrong here on the ECG. Or sometimes, if you have a protocol, a local protocol for managing of those cases, a nurse can initiate treatment. But if you don't have, in the case where you don't have the issues just to activate. So example, in the UK, before the patient reaches the emergency in the ambulance, they've even given sometimes thrombolytic therapy as they wait to go for the PCI. But in our center, now, right now, I'm heading to Umbala, assuming I find a patient who is having NSTEMI or who is having STEMI or occlusive myocardial infarction. There is no way that patient is going to make it to Kampala in time. Yet time is muscle. The best thing that I should do is thrombolytic therapy. It sounds so great, but you have to watch out for all the contraindications. And what is the sweetest, or when is the sweetest spot for you giving thrombolysis? Ideally, within 3 to 6 hours, that's the sweetest spot. But in good centers, ideally, when the patient arrives, within 30 minutes, they should have received, but there is still a benefit within 3 to 6 hours. But thereafter, the benefit decreases, but it may extend up to 12 hours. But as you do that, please get a screen list, get a screen checklist of the possible contraindication to thrombolysis in those patients. Yes, sometimes we receive patients, the patients who come and we just give thrombolysis, and by morning everything has resolved and they feel okay. Still, if they can afford to go for PCI, please still send them within 24 hours. There is an added benefit, even when you give thrombolysis, there's an added benefit of doing a PCI. I think that is it. Maybe just I got a random question here. Yes, I think I've answered part of it. Thrombolysis window. The issue is possible contraindication even to these PCI. Sometimes patients have, I think Dr. Edwin hinted on it, they have very bad or severe acute coronary, vessel disease, multi-vessel disease, whereby now you don't know, because PCI, you're going to stent 1 or 2 vessels, but you can't keep stenting everything. And these are patients that qualify for coronary artery bypass surgery, and maybe patients who are having left main disease. I don't know if Dr. Ashraf is online. He would comment on some of these things. Over to you, Chair. Thank you, presenters, and thank you, Dr. Edrin.
Thank you very much, Dr. Asad. I think Dr. Ashraf may be very busy right now. I can't see him online. But I would just like to welcome any questions from the public and from those attending online. In case you have any clarification. Some of the questions in the chat, we try to answer them directly. And then some of them have been answered through a discussion of Dr.
Maybe Dr. Kato, there are some things that mimic myocardial infarction, but lately, there is what we call spontaneous coronary artery dissection, SCAD. It may tend even to occur in relatively young women. And still, this is a place where you would be so cautious. Other equivalents, pericarditis, sometimes there are people who have treated benign early repolarization pattern as STEMI, yet it is just a benign thing. Yet the patient has gastritis, but they have pre-existing benign early repolarization. Those are some of the things that you need to watch out. Thank you, Chair.
Thank you very much, Dr. Asad. I see one of the questions in the chat. Someone is asking, what is the commonest thrombolytic around ginger? Maybe Dr. Asad, you can answer that if you may.
Okay. Yes. I think ginger, what I recall, I think, was it like about 5 years back when we started using thrombolytic therapy? But even at that time, we're using streptokinase because it was the cheapest. But lately, we have tenecteplase, maybe one thing that I have to comment about. The cost is still prohibitive for most of our patients. Now, just look at one vial of tenecteplase, about 3.2, but it's the gold, it's the standard, it's what you should have used. So we tend to move in with these cheap things, but you have to watch out for contraindications, and don't forget to pre-medicate if you're giving streptokinase and all that. So yes, streptokinase, but still on order. It's not a drug that you'll find easily, though at Nile International, I think we have some vial, we have a vial of tenecteplase, which we replace upon using. Yes, thank you.
Right, I don't see any more questions in the chat. I don't know if anyone would like to raise their hand and ask a question. Yes, Dr.
Thank you for the presentation, Dr. Carlo, Dr. Adrian, and Dr. Asad. I want to talk about a typical MI because it is very important for me and for you. About the atypical sign, particular pain, paresthesia, gastric pain, and considering that MI can happen now in any age, not in old age as before. Now in 40, 30 can happen. My question, when the doctor in emergency must do ECG for a typical form of MI, when the doctor he can call the cardiology, when the doctor he can send the patient for me for neurosurgery or general doctor or general surgeon if you have epigastric pain or some problem in the stomach. Considering also 20% of ECG, first ECG is normal. What to do in this case? Please.
Yes, thank you so much, sir, for that question. And as clearly you said, these are the atypical presentations, what we call angina equivalents. So I really emphasized the biggest chunk of my talk was on the history. If the history has been taken very well from the patient by some of the emergency department, even before running for the ECG, you have classified your symptoms. Now these are most likely cardiac, these are most, even if it's epigastric pain. Okay, let me give a scenario. The patient has epigastric pain. No, if it is inferior wall MI, the patient, the epigastric pain will be very severe. And at emergency, you're going to be prompted to give an IV bolus of omeprazole. But the patient is still groaning. The patient is sweating, you know. So your suspicion is high. Your suspicion is high at that point of a possible inferior wall MI. So you do the ECG and then you see, boom, you see the symptoms. So if you leave your history without clearly having a clue that, okay, this is most likely cardiac, because the moment it's most likely cardiac, even you follow up ECGs, you follow up the patient before handing him over. Because if you send to the neurosurgeon, to send to the general surgeon to do an endoscopy, and then the patient does an inferior MI, even that the patient is going to die from there. He's going to die from when they're doing the endoscopy. So I think it's all about how much you're really living the history when you're really certain that this is most likely cardiac, the patient is diabetic, he's a female, she's elderly, very likely to have an angina equivalent. So if it's like that, then I think that doing the ECG and then the troponin and the one, then it makes you likely before concluding to send to another specialty that the patient is most likely cardiac or not. But at that point, I think I also call Dr. Asad if you have something to say about that. Dr. Kami's special.
I think, Adrian, you've said it all. Maybe the issue is just having a high index of suspicion. And maybe in such cases, that is where I would recommend sequential testing, sequential ECGs, sequential troponin tester, or sometimes, and doing the cardiac marker of interest. There's a tendency of people, patient has come in about 2 weeks, you're doing CKMB. You don't want to get anything there. CKMB has been washed out. Why don't you go for troponins? So yes, so it high index of suspicion, sequential ECG or sequential diagnostics, sequential troponins, sequential ECGs. Yes, that is what I should do. That is what I should recommend. And still, it doesn't hurt starting relevant treatment as you wait for key diagnostics. I think, Dr. Edrin, is that a patient you managed last week or 2 weeks back, whereby the ECG later started showing the following day, but just before that, you'd started treatment. Was that the case?
Yeah. We had some, it was an Indian patient. Yes.
Yes, exactly. So the issue is high index of suspicion. Start management. You don't lose a thing unless there are contraindications to that management as you do sequential tests. Thank you.
Yeah, and someone has just sent in a question: how best can we manage MI in a post-surgical patient? Dr. Sad clearly talked of the risks. We have what we call the Hasbled score. So a patient has had bleeding in the brain, they have done surgery, and at that point, you are not going to give fibrinolysis. The only alternative is to do PCI because of the risk of bleeding. So we have that, you can look at the Hasbled score that makes you think of, is this patient really suitable for fibrinolysis or not? I think that's important. PCI may be the best in such a patient who has just had surgery. So the risk of bleeding is very high when you give up artificial or something like that.
Then there's a question, can a teenager get acute coronary syndrome? Maybe what I would say, they may get non-occlusive myocardial infarction. However, I've seen relatively young people getting acute coronary syndrome, but not all ST elevation is actual acute coronary syndrome. You need to watch out for that. But yes, teenagers can get anginas, especially vasospastic angina. But that does not necessarily mean that they're having occlusion. Bottom line, you need to know your patient. Thank you. Yes, and I also agree with Jamal. Yeah, the too much obesity. But still, you have to risk stratify your patient very well. Yeah. Chair, is the presentation done? Can I log off?
Dr. Karama has a question one, but I think it's far from the mic. Yeah, they can't hear. One last question, and we call it today.
In maybe very remote areas where say someone doesn't have an ECG, no any possibility of say doing a troponin and CKMB, how would you advise in such a setting how to diagnose a patient with MI? And secondly, yeah, that's the first one. Secondly, I needed more enlightenment on differentials. What else would present as MI? What is it that we should watch out when we are down there at A&E that you can very, very much miss, say, A thinking it's big, the differentials? Thank you.
Yes, thank you so much for that question. Like, if someone is in a place where they cannot do an ECG, how can they diagnose MI? As we saw, the entry point to acute coronary syndrome diagnosis has history. So he's going to rely on his clinical history, but there's so much risk with that. But at least he can do something, because you don't know if you have any ST elevation MI, or you don't know what you have. But what you think you can do at that point, give some subcutaneous Clexane, even if it's a PE, then you're giving some aspirin while covering the stomach. If you have some clopidogrel, as you're calling the ambulance. One thing in an emergency is call for help. So if you're down in the village, shout for help, call for the ambulance, do things that may not kill the patient. I would advise you, if you can give aspirin oil protecting the stomach, give clopidogrel, then you're hoping that you don't have aortic dissection. So that means you stay in prayer as you're referring the patient. So, but the most important thing is really let them reach the point like here now hospital where there is an ECG that can be done. And then second question, the differentials of chest pain are broad in an acute setting. Recently, I've just had a 25-year-old with a PE from brought in from Iganga. So you just can't take all chest pain as acute coronary syndrome. All you need to be would be well grounded while taking your history. As I said, there's nothing that causes a lot of confusion for clinician like living history when you don't know where you are. Take the history, have almost 50% suspicion that, okay, this is the heart that is sick. Okay, now because this was a young girl, even contraceptives, then a PE is likely. So you take your history very well, and then because you have aortic dissection, you can have a pneumonia, ulcer pain can give you, pleuritic pain can come, esophageal dissection can cause chest pain, as in there are so many, even anxiety. In these young girls, the teenagers they were talking about, they come from school with a lot of hysteria, conversion syndrome. They come with a typical chest pain. So you just have to be well grounded, say that by the time you're leaving your history, I really emphasize that there is nothing that causes more confusion like doing investigations and you hope to save yourself. Investigation should just pull you into the right direction that you're suspecting. So anyway, there are so many possible causes of chest pain. I don't know if Dr. Assad has something to wrap up this meeting. We are almost on top of the hour. The patients are waiting.
Oh yes. Maybe just follow up on the question regarding someone in a remote place. My encouragement generally that we need to demystify some of these tests. An ECG should be able to be done even in a remote centers. That's a call that we should give to people. The only difference, they may not be able to interpret it, but nowadays gadgets have come. Do an ECG, send it somewhere. I think Dr. Sebata was trying to form up with a platform whereby someone can be in a remote center, do the ECG, send it for interpretation. That is the way to go. But in the absence of that, yes, still our clinical skills are the bailout in all circumstances. And I usually tell people, if you are thinking, so assuming it is a stroke, and you feel you don't have a CT scan at your facility, then that patient is not yours. Just do tentative empirical therapy, send to the next center. The patient is not yours. Same applies. If you think it's acute coronary syndrome, yes, give your due and platelets and what you can, and then send the patient to the facility where they deserve to be. That's my recommendation. Allow me also, I'm on a journey. Allow me also to end here. Thanks, presenters. Thank you, Dr. Edwin, for the moderation. Thank you.
Thank you very much, everyone that has attended. Thank you very much, Dr. Edwin, Dr. Assad, Dr. Ashraf, and all the team that works together to come up with the presentation. There are lots and lots of questions coming through in the chat, but because of time, we're going to have to end this presentation here. And you shared your emails with us. We shall share the presentation and the slides and answer any other questions that we haven't answered in the presentation. Thank you very much. Have a good day.